Thank you so much. I have to reflect back to the very first SAGES-sponsored adolescent bariatric surgery panel program. Mark, I don't know if you remember, Janie, but early, mid-2000s, and we spent the entire time arguing about whether we should be considering doing this craziness to teenagers at all. And of course, if we were going to do it, the only option was the lap band, because that made sense. You'd put in, you wouldn't hurt the kid, and you'd take it out. So things have changed. Nothing to disclose. So obviously for us, and I don't need to state this to this group necessarily, but pediatric obesity has become an epidemic like COVID, I guess. 40 million children under the age of 5 recently, and 330 million young kids reported by the World Health Organization. It's not the obesity, obviously, it's the complications. And so for us, it's the cardiometabolic risk factors, specifically hypertension, type 2 diabetes, respiratory disease like obstructive sleep apnea. These are the things that we're targeting with the consideration of bariatric surgery in kids and teenagers. Now, for us in the pediatric world, we're all the time talking about BMI percentile and percentages. And just to make it simple, we're talking about indications for surgery being BMI of over 35 with a serious comorbidity, or perhaps over 40 with a less serious comorbidity. Most of the patients we operate on have complications of their obesity. It's not just driven by the BMI. Patient selection, again, this is a list of the complications or comorbidities that we see frequently in our teenagers that push us to consider surgery. There are some contraindications, maybe a little bit unique to kids in some way. If you have a medically correctable cause of your obesity, like you're leptin deficient, and we can give you recombinant leptin and you'll lose the weight, perhaps you don't need bariatric surgery. Substance abuse, the ability to cooperate post-op. You know, teenagers are by definition not cooperative. They're not compliant. Mom says do this, you do that. And here we are operating on them and saying, now after surgery, you have to follow the rules. And so that can be a real challenge for us. Well, I mentioned this, adjustable gastric banding was the first thing on the list for us to consider in teenagers. And I will just show one results slide that's driven by Dr. Mikowski, sitting on the front row over here, looking at adjustable gastric banding in teenagers. The dark line is change in BMI, and you can see that over time this has not worked out well for us in teenagers. So these are the two things on the menu for us to consider. Roux-en-Y gastric bypass, been around the longest, and the teenagers shift over to sleeve gastrectomy after the adult world did. This made some sense to many people in the pediatric world because it would be a lesser of an operation and fewer complications in a teenager. And if later on in life they had to be converted to a Roux-en-Y gastric bypass for reflux or something like that, those of us in the pediatric side could just turn that over to our adult colleagues to deal with. So we like the sleeve to a great extent. So I'm going to share data from the Teen Labs Consortium. That's a multi-center prospective NIH-funded trial, been going on since 2007. This is just looking at a publication from 2015 when we published our 3-year teenage weight loss data. Comparing sleeves to bypass, though, this study started really with just bypass and slowly over time shifted a bit more to sleeves. But you can see approximately a 30% change in weight or BMI at the 3-year mark, and pretty similar between the sleeve and the bypass. More importantly, we found that those complications that we were targeting also got better. So again, looking at 3-year data from the same Teen Labs study, looking at dyslipidemia, which happens in about 75% of the teenagers presenting for bariatric surgery. You can see good results with resolution of dyslipidemia both in the bypass and the sleeve, although bypass seems a bit more robust at 3 years. So our conclusion of 3-year outcomes for adolescent bariatric surgery was a durable, clinical, meaningful weight loss at 3 years at least, and improvement in key health conditions. But we were worried about micronutrient deficiencies, especially in the bypass patients. So a few years later, we published 5-year data. Again, this is the Teen Labs Consortium. And we compared the Teen Labs to the NIH-funded LABS data, longitudinal assessment of bariatric surgery in adults. to see if adolescents and adults behave similarly or differently. This is just looking at weight change from baseline. Again, the adults are in the yellow and the teenagers are in blue. And you can see at 3, 4, 5 years, very similar weight change results, again at the 25 to 26, 27% weight change for both teens and adults. We were surprised and pleased to see that some of the remission of our comorbidities like type 2 diabetes seemed to be a bit more robust in the teenagers. So at 4 and 5 years, you can see that remission of type 2 diabetes in the teenagers is a little bit higher than that for the adults. Likewise, for hypertension. Again, this is 5-year data, not 25-year data, so we don't know what happens long term. This is just a table that I want to point out some things. We don't like the idea of death in any of our patients, but a teenager dying after a bariatric surgery operation is a big deal, and there are some. Not too much related directly to the surgery itself. Could be suicide, could be other things, but similar to adults in the 5-year follow-up, and this is looking at an unusual way of looking at the data. We also found that incidence of intra-abdominal operations in the teenagers after bariatric surgery was actually higher than adults. Don't really have a great explanation for that. A lot of the teenagers got cholecystectomies after their bariatric surgery, but something to pay attention to going forward. So comparing teenagers to adults, adolescents and adults who underwent this is just gastric bypass in the 5-year data, had similar results to the weight loss and perhaps slight improvement in remission of some of the comorbidities. This is just a more recent study looking at what if you lost a lot of weight early on or didn't lose much weight early on, looking at comorbidities. And I'll just conclude by saying both groups of patients improved in terms of their comorbidities, but if you lost a lot of weight, you really had a significant change in your dyslipidemia profile over 5 years. I have a real interest in quality of life in these patients, and this was a study from Alabama a long time ago when I was there. Just simply looking at a group of teenagers whose BMI started at 50, and now they're 35 to 40, but their quality of life perception went from the blue line compared to the green line, which is normal weight young adults, to 1 year post-op being the pink line, showing that they had self-perception of improved quality of life, still with a BMI of 35 or 40, but compared to 50 or 60, they perceive their quality of life to be much improved. Now not advancing. Okay, I'll do that now. So summarizing, here's a list of risks for bariatric surgery in teenagers. Micronutrient deficiency, osteoporosis, more abdominal operations in the future than we really understand, severe reflux as with adults for the sleeve gastrectomy, weight regain, drug abuse, alcohol abuse, and we worry about their ability to really understand and consent to the procedure. Benefits, there appears to be a good average body mass weight loss of about 25 to 29% and resolution of a lot of these complications that are really critical to what we're trying to achieve in these young people. And I can't help but just show examples. I've done this before at this meeting, so just forgive me for a second. So 16-year-old, lots of complications. 2 years later, BMI of 27. Young man, 15, BMI of 60. 1 year later, BMI is down to 40, but he thinks he's cool. He's growing a beard. He's got his hat on backwards, really thinks he's the thing. Young woman, BMI of 17, age of 17, BMI 47. And then 2 years later was a nursing student at UAB and very happy with her results. This young man, I asked them all, why do you think you're interested in surgery? And he said, I want to be a Marine. They won't let me be a Marine like this. So he wanted to be a Marine, and he had surgery. 2 years post-op, BMI down to 30. He went to join the Marines and said, you can't be a Marine. You've had a gastric bypass. So he's a cop and very happy. My first patient wanted to play football in high school in Alabama, which is a big deal, and so he managed to do that. And then just clip through some more recent Buffalo patients. So with that, I will stop, and thank you very much for the opportunity to share some data and the results, and look forward to the rest of the session. Thank you.